In today's episode, we are going over an evidence-based guide to lateral epicondylalgia, aka tennis elbow. Let's do it. First and foremost, thank you so much for your support. You truly allow me to do what I love for a living, and that's fitness, that's physical therapy, that's spreading this information. My name is Dan Pope. I'm a physical therapist, coach, personal trainer, and meathead. I love all things weight training and fitness. That's me. This is the Fitness Pain Free Show where we help coaches and physical therapists like you get your patients out of pain and back to training. If you're watching this on YouTube, please hit that like button, comment, and subscribe to the channel. If you're listening to this on the podcast format, please leave a positive rating. It helps me out tremendously. And if you want to support the channel even further, consider subscribing to Fitness Pain Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. Think Netflix, but for personal trainers and physical therapists. It has premium content updated by me. I've been updating this for the past 5 or 6 years or so. We have over 100 webinars, ebooks, and comprehensive guides. You can also get your answers, any questions you have answered by me. You have access to me in a private Facebook group. So if you want to ask something specific, you have access, right? And the best part is that you can get access to this for just $1. So it's a $12.99 per month membership. However, you can get started for $1. It is the best way to support me. So please head over to fitnesspainfree.com, click on the programs link, then click on Fitness Pain Free Insiders Online Library to get started. I'll also leave a link in the show notes. What is the prevalence of a lateral epicondylalgia? So lateral epicondylalgia, I'm going to try my best not to butcher that 1,000 times over the next 30 minutes of making this, is more commonly known as tennis elbow. And what's kind of interesting as a stat, only 50% of tennis players actually get this over the course of their entire career, right? And of those tennis players that end up getting tennis elbow, they only make up 5% of the entire population of people who end up getting this and having pain, right? It is actually the most common type of elbow pain out there and affects somewhere between 1% and 3% of the population at any given time. That's the United States population, right? Primarily is going to affect folks from the age of 35 to 54 years old, and approximately 40% of people will experience tennis elbow at some point over the course of their life, okay? So it's quite a common thing to get. Tennis elbow actually has a pretty high societal impact, right? And basically what that means is that if you get tennis elbow, it ends up being debilitating, and because of that, we have increased costs. And that's going to come from absenteeism from work and also healthcare costs, right? So if you get tennis elbow, the average time away from work can be up to 219 work days, right? That's quite a bit. The other part is it's going to cause a direct cost of about $8,099 per person. And that's going to be in loss of work combined with healthcare costs of trying to get rid of this problem that people have on the side of their elbow, right? The other thing that I think is very important that's not really measured as much and probably more challenging to measure is the indirect cost of not being able to exercise because your elbow hurts, okay? So if you get any sort of injury, and this is not just tennis elbow, it's going to be a threat to being healthy, right? So if you're not exercising, you're increasing your risk of things like heart disease and diabetes, premature death, and just spending more healthcare dollars from simply not being healthy, okay? So I think generally speaking, we want to make sure that we can fix these issues when they pop up so that we can avoid some of these costs over the course of time. So tennis elbow is basically a tendinopathy injury to the extensor muscles of the forearm. So the wrist extensor muscles will attach to the outside of your elbow. That's called the lateral epicondyle, right? Those muscles turn into a tendon. A tendon attaches to a bone, which is your humerus. And the pain is originating, what we think is originating from, is going to be from the tendon itself, okay? And that's where that injury is coming from. So the next natural conversation is going to be tendinitis versus tendinosis or tendinopathy, right? So initially we thought tennis elbow was mostly inflammatory, right? When we think tendinitis, that itis means inflammation, all right? However, over the course of time, we took biopsies of chronic tennis elbow tendons, and we found there's an absence of inflammatory cells. There are some specific inflammatory cytokines that are going to be there, but it's not the same as a traditional inflammatory response, okay? So natural conclusion is this is more likely what's called a tendinosis. And what this is a symptomatic degenerative process associated with increased fibroblasts, vascular hyperplasia, and unstructured collagen, right? And there's no complete correlation between the degree of tendinosis and symptoms, right? And you don't need to get rid of this tendinosis in order to get out of pain and back to your life. So, what is the etiology of this? What is that mechanism of injury? Well, we think it's from excessive gripping, wrist extension, radial deviation, or wrist supination. So, basically, too much work for the wrist extensors, right? The involved tendons are going to be the tendons coming from the common wrist extensors, where the tendon originates on the humerus. The most common muscle that's involved is the ECRB, or extensor carpi radialis brevis, and it's involved in about 95% of all cases. Other muscles that can be involved are the extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris, but keep in mind, these are not as commonly involved. What's the natural history of tennis elbow? Tennis elbow is actually pretty interesting as a pathology because most folks do tend to get better over the course of time. So, in most cases, we call this a self limiting condition, which basically just means that over the course of time, people don't do as much with their grip muscles and don't do as much gripping activity because it hurts. And over the course of time, this naturally gets better, right? So about 80% of cases are resolved by the 1 year mark. And this is actually pretty variable based on the research paper that you end up reading, right? But the large majority of cases are actually going to heal within about 3 months, right? The one thing I will keep in mind as a physical therapist is that you're probably not seeing these patients. So the folks that get better really quickly are oftentimes the folks that just don't end up going to seek treatment, all right? So if you are seeing someone, it's probably going to be a little bit different than the large majority of folks that end up naturally having some success over the course of time. Although most cases are self-limiting in a select group, they do not revert to the mean, meaning that their pain just kind of extends for months to years after they've had this injury, right? So 17% of patients with tennis elbow have symptoms greater than 1 year out. Okay. Over 50% of patients attending general practice for elbow pain report not being recovered at 12 months. And those with a high baseline severity were 5.5 times more likely to still have symptoms of tennis elbow at the year mark. So the folks that have really bad pain are more likely to have symptoms for longer, right? And you also have to make sure that you understand that a lot of the folks who are coming to see you might not have this natural history that is described in the medical literature, okay? So this is a bit of a clinical pearl. We have to make sure we don't minimize patient experience. Okay. Like I said, we see the outliers, and these folks have not had this natural resolution, right? That a lot of other folks had. And we can't go ahead and tell them, like, look, this is not a big deal. It's just going to get better. Don't worry about it. Because for some folks, that's not the case, especially if it's very bad pain wise at the start and it hasn't gotten better by the year mark, right? So the other thing I think is important to understand is that exercise is a greater and faster reduction tool for pain than just waiting and seeing. Okay. I often hear the opinion that because tennis elbow naturally gets better over the course of time, and we don't have to treat it whatsoever, right? Because it's just going to get better. Well, two thoughts. A, yeah, that could be absolutely fine, right? But B, if we apply exercises, folks are probably going to get better a little bit faster. And C, in some folks, they actually may need some exercise in order to get better. So I think it's important that we're not just giving this blanket advice of like, it's fine, right? You'll get better over the course of time, because I see so many patients that come to me that have been told that, but things have not improved. So what is the mechanism of injury for tennis elbow, right? So the biggest one you'll see is overload or overuse of the gripping muscles, the wrist extensor muscles. So over the course of time, this can just lead to some pain. All right. So if you're doing way more than the wrist muscles are prepared to handle, and over the course of time, you can end up with some pain, right? That makes a ton of sense. We also have a little bit of research about psychosocial variables or psychological factors that are correlated with tennis elbow. One of those being work stress, and the other one being certain personalities, right? If you have obviously too much stress in a given area, that can cause a problem. But the other piece of that puzzle is recovery, right? So theoretically, if we're well recovered, well fed, sleeping well, low stress, we're probably able to handle a little bit more stress to the lateral elbow than if we're super stressed out, right? And that kind of makes sense. So optimal recovery is going to be very important for preventing future injuries, obviously. But after you have an injury, it's also important for getting out of pain, right? If you guys want to go really in depth on this topic, I recommend right now going and checking out the Fitness Pain Free mini course. I'll put this link in the show notes and it'll go over all these potential mechanisms of injury, how people get hurt in the gym, right? And how you can start helping folks get out of pain and back to training. So, what does the clinical evaluation look like for tennis elbow, right? I'm a physical therapist. This is how I'd run someone through an evaluation that I suspect they have lateral epicondylalgia. So let's go through the subjective portion first. So, what do these patients complain of? Well, they complain of some sort of pain or burning around the lateral epicondyle. And this radiates down the forearm typically and potentially up into the upper arm. So it's not just pain in the lateral epicondyle and into the wrist extensors. It can be up into the tricep region, into the bicep region a little bit as well, right? These patients tend to complain of weakness in grip and difficulty lifting, right? Basically, anything that causes you to grip or extend your wrist can be aggravating. It tends to hurt with gripping, opening jars, and manual labor. I'm a physical therapist that works with a lot of people in strength and fitness, and it typically hurts with any sort of gripping. So, holding on to a barbell for deadlifts or Olympic lifts, holding on to a bar for pull ups, muscle ups, whatever, any sort of gripping tends to really kill these folks, right? The other piece you'll find is usually some tenderness at the lateral epicondyle at the ECRB origin. What are some of the objective deficits we may find in these patients? Well, for one, weak or painful grip, right? And you can do this with a handheld dynamometer just to see what the difference is from side to side. And if it's significantly weaker, it's a good chance you're dealing with some tennis elbow, especially if it's hurting in the lateral epicondyle, right? Generally, you're going to find weak and painful wrist extension. And you can also find some pain with resisted middle finger and ring finger extension, which is thought to kind of rule in that ECRB as a generator of pain. What other objective findings might we see? So, one, weak and decreased endurance of a bunch of the musculature around the entire arm. Okay. So, when someone has tennis elbow, it's not just an elbow issue. Oftentimes, it's weakness in the entire arm. So, you may find some weakness and decreased endurance of some of the muscles around the shoulder, right? Which muscles are we talking about? Well, one study was looking at the serratus anterior, and the low and mid trap, and they found they had decreased endurance and strength, although these were small differences. And I think that's important to take into account. You also may find some weakness into external rotation, shoulder abduction, and internal rotation, right? So if you look at all of those movements that may be limited, that's a lot. It's kind of like everything the shoulder does, basically. You also may find some scapular dyskinesis, which is reduced symmetry on the involved side. Just make sure you understand that dyskinesis is not the be all end all, but maybe a player potentially. These folks tend to have widespread hyperalgesia or central sensitivity. Basically, we think that the brain and the rest of the nervous system has a heightened awareness, giving us a bit more pain than maybe what is normal. The folks that tend to have widespread hyperalgesia tend to have higher pain levels, lower function levels, and a longer symptom duration. So, what are the special tests for tennis elbow? Well, there's a lot of them. And I think the first thing to understand is that not all of these tests have a lot of great research in order to back up the effectiveness of picking up whether or not this is the problem in your elbow. The other piece is that the gold standard they use to judge these tests is going to vary from study to study. And we do know that if you have an MRI diagnosis of tendinopathy, doesn't necessarily mean that you have pain. All right. So take these numbers with a grain of salt. They are pretty good to try to rule in or rule out this pathology. The first test, chairlift test. And I've seen this described in a variety of different ways, but basically all you're doing is having your patient walk up to a chair, grip the top of the chair with the arms pronated, elbows extended, and lift the chair up and see if that reproduces the patient's normal or familiar pain on the outside of the elbow, right? I've also seen this test described with a pinch grip between the thumb and the first two fingers. So pinching the chair and trying to lift up from that position. The next test that's very popular is a Cozen's test, which is basically a resisted wrist extension test. So basically you have the patient sit down, extend their elbow. They're going to radial deviate their wrist, extend the wrist. And from here, we're going to resist wrist extension. If they have a reproduction of their pain on the outside of the elbow, reproduce those familiar symptoms, that would be a positive test. This test has a 91% sensitivity. So good at ruling out issues, but it has a poor specificity. So you can't rule in tennis elbow very well with this test. The next test is the Mills test. And the Mills test, you're basically just stretching all the wrist extensors, right? So the patient is seated. The clinician palpates the patient's lateral epicondyle while pronating the patient's forearm, flexing the wrist with the elbow extended. A positive test is pain of the lateral epicondyle. And this test has a pretty poor sensitivity of 53%, but a pretty high specificity, right? So if someone has a negative test, we can't really rule out lateral epicondylalgia well, but if they have a positive test, that's pretty good at ruling in tennis elbow, okay? We can also use a few other special tests. So if someone has grip weakness, that has an 83% accuracy of diagnosing tennis elbow. You can also do a resisted middle finger test, so resisted middle or ring finger test, and that's thought to provoke the ECRB if that's involved. The other test that's pretty interesting is testing strength of the grip with the elbow extended versus flexed to 90 degrees. And we have a little bit of research to show that if you have more weakness with gripping with the elbow extended, that increases the likelihood that you have tennis elbow, right? And the thought being, again, that if I grip with my elbow extended, I'm at least the same strength wise and probably a little bit stronger than gripping with my elbow bent at 90 degrees, right? So if I have pain on the side of my elbow associated with tennis elbow and I extend my elbow and I grip, I may be weaker in that position because I'm putting a little stress on that tendinopathy region of the tendon that hurts, okay? And this test actually has a decent sensitivity at 78 to 83% and a decent specificity of 80 to 90%. Okay. So these three tests I would use to try to evaluate for tennis elbow: Mills, Cozen, as well as this grip test here at 90 degrees of elbow flexion and at 0 degrees in full extension. What's the differential diagnosis of tennis elbow? There's a few different diagnoses that could masquerade as tennis elbow, right? One of them being cervical radiculopathy. You want to screen out the neck to make sure that pain on the outside of the arm is not coming from a nerve root injury. Okay. You also could be dealing with a bit of frozen shoulder that causes some pain down to the elbow. All right. So make sure you're ruling out any sort of shoulder pathology. You might be dealing with a radial tunnel syndrome. So more of a nerve injury. So the radial nerve is going to travel down the outside of the elbow where folks can have tennis elbow symptoms, right? Might be dealing with a lateral plica syndrome problem. Posterior lateral elbow instability could masquerade as tennis elbow. You could be dealing with an inflammatory edema problem. And really, you want to rule out for any sort of humeral radial joint pathology, right? So basically, if you have pain in your humeral radial joint, that sits right next to the lateral epicondyle. So make sure you're ruling these things out before you start treating someone for tennis elbow. What is the treatment for tennis elbow? So this is a great thing, but generally speaking, non-operative treatment is going to resolve about 90% of cases, right? What is non-operative treatment? So first and foremost, it's generally some sort of activity modification and some sort of physiotherapy or physical therapy if you're from the United States, right? Other common forms of treatment are NSAIDs, bracing, extracorporeal shockwave therapy, orthobiologics like PRP, and lastly, exercise, which is going to fit into that physical therapy bucket. We'll talk about exercise a little bit later, right? How about surgery? Do these folks need surgery? Typically, no, right? Like I said, 90% of all cases are going to resolve over the course of time, right? There's no strong evidence that operative treatment is superior to conservative treatment or a wait and watch policy, right? So if I just wait over the course of time, that might actually get my symptoms to go away. I might not have to do anything, right? So you only want to reserve surgery for the minority of patients in select cases that don't get better over the course of time. So what's the best type of exercise for tennis elbow, right? So generally speaking, as you look over the research about tennis elbow treatment using exercise or physical therapy, you're going to see a lot of exercises targeting the wrist extensors. Okay. So targeting the wrist extensors is going to be the way to go to help these folks. It's your primary treatment from an exercise and physical therapy standpoint, right? However, what type of exercise is best? Is it eccentrics, concentrics, isometrics, a combination of both? What should you do, right? So let's look at some of these studies. In one study, when they were comparing eccentrics versus concentrics, so basically in one group, they did a lowering of a weight in a fully extended wrist position down to a fully flexed position. So basically eccentrically lowering the weight, right? And then lifting it back up with your hand. So taking away the concentric portion of the lift. And they compared that against concentric only lifting, which is basically your wrist is fully flexed. You grab onto a weight, you extend with the load, and then you help with the opposite side arm to eliminate the eccentric portion. And you compare the two exercises to see what's best for tennis elbow. And what they found is that eccentrics were superior because they gave a faster reduction in pain and greater improvements in strength. Okay. So let's take a look at the next study where they're comparing eccentrics versus eccentrics plus concentrics versus eccentrics plus concentrics plus isometrics, right? So eccentrics versus up and down and also holding a position with a load. So if you use eccentrics, concentrics, and isometrics, that seems to work the best for these folks, right? Another study I looked at, they were looking at the difference between eccentrics and isotonics. So an isotonic is going to be eccentric plus concentric, right? Are eccentrics better than isotonics, right? And they had two studies in this analysis. So I think at the end of the day, we don't know for certain what the best type of exercise is for tennis elbow. But at least in this study, they actually showed that eccentrics had a greater reduction in pain. However, there's no difference in strength and there's no difference in function, right? So use the DASH outcome measure as a measure of function. There's no difference between the groups. So you'll also find a little bit of research where the combined wrist and standard physical therapy, right, for the wrist extensors, and they combine it with some shoulder exercises, right? And what they find is that when you combine your shoulder exercise with wrist exercises, they had superior results over just the wrist extension treatment, right? So it may be beneficial to add some shoulder strengthening on top of your wrist strengthening, right? And here's the thing. There's not a ton of great research on this quite yet, right? And it sounds like you have benefit from doing all of these things. Some of the research is mixed. It does seem that maybe eccentrics is on top at this point, right? Who knows when that next research study comes out, it might not show a big difference. I think for a lot of folks, this becomes very confusing because we're not really sure what the best exercise is to apply to a patient. Well, in my mind, this just means that we have a lot of options, right? We can do some eccentrics, some concentrics, some isometrics. We'll add some shoulder strengthening in there. I think that we just have a lot of options and we can meet the patient where they are, right? In terms of how irritated they are. We can also plan to be more specific over the course of time with our exercise selection so they can get back to tennis, baseball, weightlifting, whatever it is. So at least in my mind, I'm glad that a variety of exercises have shown to help. And if I apply it over the course of time, they're probably going to get better, right? So use your brain and try to critically reason when you're giving exercises to your patients. So what's the optimal duration of treatment for tennis elbow, right? So I tried to look at a variety of studies to see what the optimal amount of time is for you to treat someone with tennis elbow for them to get better, right? And this was actually a little confusing. And I think at the end of the day, more research is going to be needed, right? So at least in this study, they had 7 studies included. It was a meta-analysis. And the duration of treatment was anywhere between 2 weeks and 12 weeks long, right? The majority of folks did make some progress here. So it didn't say much about which was best and how long people need to be treated to get rid of their pain, though, right? So again, more research is needed. And at least in my mind, the amount of time it takes for someone to get better, it's just going to be very variable. You treat people until they're finished, right? Or till they feel like they're happy with the amount of pain reduction they've gotten. So here are the references. I'll leave them in the show notes for you to check out. Thank you so much for joining me today. If you're watching on YouTube, like, comment, and subscribe. I'd love to hear your thoughts. If you're listening to the podcast version of this, please head over to iTunes and give me a positive rating and review. Helps me a ton. Thank you very much. I'll see you on the next one.